Very good evening. Thank you, Dr. Deni, for the introduction. And thank you for AstraZeneca for giving me this opportunity. So I'll share my slide in between. I hope this is visible, right?
Yes, Bios.
Thank you. So the talk is the turning the tide for Stage III NSCLC towards the curative intent. Yes, as Dr. Denny said, for almost for a 3 decade, the radiation, chemoradiation, concurrent, sequential was the standard of care for stage 3 lung cancer with the cure rate is definitely modest. Now, with the invent of this durvalumab and subsequent study, that shows that the outcome has been improved by many fold, and maybe sometime we can say a telling effect with the long-term responder to immunotherapy. So let's go to the introductory part. This is a Globocan 2020 data. We all know almost 70,000 new lung cancer been diagnosed in India every year. And ultimately, most are going to die because of advanced stage, and lung cancer being the most common cause of cancer-related mortality, not only in India, but worldwide. So this is the expected breakup of how they present. So 10 to 15% will be a localized resectable disease, and then another 30 to 35% will be locally advanced unresectable, and 55% will be approximately metastatic. In India, I think the data says that the metastatic rate can be as high as 65 to 70%. And so almost 1/3 patient in a nutshell that has locally advanced disease, where we do treat them with CTRT with curative intent, and the question is whether we can improve their outcome or not. So multidisciplinary management is very much important for management of all lung cancer, not only stage 3, but from stage 1 to stage 4. More so in stage 3 locally advanced, because here the tri-modality treatment comes. Sometimes we give them neoadjuvant chemotherapy and a trial and to see whether they become resectable. If not, we go to sequential approach. We do treat them with concurrent CTRT. But it's important to see many aspects of a certain patient before treating them. Their performance status, their histology, stage of the disease. We do PET CT MRI in each and every patient at our institute as a part of the staging, and the pathological sampling of the mediastinum. Sometimes it's most of the cases important other than the frank metastatic cases. So EBUS, TPNA plus minus endoscopy. So here involves the roles of pulmonologist, pathologist, radiation oncologist, medical oncologist, and thoracic surgeon, and definitely physiotherapists and many other the thoracic nurses. They play their each role. So it's a various facets of management of lung cancer patient, and in our institute we discuss each and every case in thoracic DMG. So the pulmonary function, bronchoscopy, FDG PET, MRI, medicinal staging, cardiac function, and other routine performance status also is important before deciding a therapy for each and every patient. And especially in stage 3 lung cancer and unresectable cases, that this modality, the all modality of treatment comes, the medical oncologist, radiation oncologist, pulmonologist role is very crucial. The current standard of care for all stage 3 locally advanced unresectable lung cancer NSCLC is chemoradiation. We know the result is much better than radiation alone, and also the clinical trial data said that concurrent chemoradiation has a better outcome than sequential chemoradiation. At the end of the day, in 30% cases, patients are not fit for concurrent chemoradiation, so they underwent sequential chemoradiation. And the percentage vary from region to region, practice, and institute. So this is the overall guidelines. Definitely for all patients with localized from stage 1 to stage 3A, they are resectable, including neoadjuvant chemotherapy followed by surgery or surgery followed by adjuvant chemotherapy. If the tumor size more than 4 centimeter and node positive, very few single station non-bulky N2 patient may undergo neoadjuvant chemotherapy followed by surgery, but in most cases, the multi-station of the bulky N2 or N3, they are unresectable, or even in multi-station N2, even if they are resectable, that doesn't improve the outcome. So they are being treated in with chemoradiations, and definitely those who are not fit for chemoradiation, they undergo palliative treatment. So mediastinal staging is important, and there are now clear-cut guidelines for which are the patients who should undergo EVAS TVNA plus minus mediastinoscopy. So here we are discussing this unresectable N2 or the multimodal station N2 or N3. So this is the for all patient undergoing curative intent therapy with concurrent chemoradiation. whenever it's feasible. If the patient is not fit for concurrent, we do try for sequential accommodation. Even if the pulmonary function or the performance status doesn't allow us to treat with curative intent, then sometimes patient do receive only radical or palliative systemic therapy in case of very poor lung function. And there are data that many chemotherapeutic agent or protocol has been used as a part of concurrent and sequential accommodation. But as I said, the outcome remains not very good. Ultimately, at the end of the day, the 5-year event-free survival, or the 5-year OS remains 15 to 20% in patient with stage 3 unresectable NSCLC after concurrent or sequential chemoradiation. So there has been various approach has been used to as a consolidation treatment to improve their outcome, like consolidation chemotherapy, like consolidation with higher dose of radiotherapy or geftotin. So these are the various chemotherapy regimen used with radiotherapy in NSCLC treatment. If you see, so start with the initial cisplatin lymphocyte, cisplatin immunoglobulin, then we have era of pemetrexed carboplatin, pemetrexed cisplatin, paclitaxel carboplatin. So almost all the study shows comparable outcome. So whatever is feasible as per the historical practice and the comfortable of the patient and the physician and the institute should be used. In our institute, mostly we use cisplatin lymphocyte, and a few of the cases where we feel the patient will not tolerate cisplatin lymphocyte or there's a high chance of toxicity, we do use weekly paclitaxel carboplatin. And these are the sequential chemo regimen. I think we use histology-based therapy. For squamous, we use paclitaxel carboplatin. For adeno, we use pemetrexed-based therapy, platinum doublet. So these are the consolidation trial that I was discussing, used in locally advanced NSCLC with one motto to improve the overall survival or the cure rate. So consolidation docetaxel, consolidation docetaxel cisplatin. We have a big PROCLAIM study with pemetrexed cisplatin versus cisplatin lymphocyte. We have RTOG 0617 higher dose up to 74 degree of thoracic RT. We have consolidation trial with geftotinib or anti-EGFR antibody. None of the trial failed to show any OS benefit as compared to the chemoradiation alone. That means all the consolidation strategy failed to improve the overall survival in addition to the chemoradiation. So before this study came, the standard of care was only chemoradiation, be it concurrent and sequential, and then keep the patient on follow-up. And as we know that most of the patient, 80 to 85% of the patient is going to progress or recur in subsequent 6 months to 2 years of time. So traditionally, as I said, the treatment was curative intensity only. Then there came the era of immuno-oncology, and now we are discussing about durvalumab. So the trial has been done with durvalumab maintenance after chemoradiation. The logic behind this trial is that the chemoradiation causes cell killing that leads to many too much of antigen production after the cell death, and those antigen is present on the cell surface as a new antigen, and there is PD-L1 overexpression. And as we know that in case of PD-L1 overexpression, there will be higher PD-1 PD-L1 interaction and energy, and if you block that interaction, then definitely immunotherapy has a higher tumor control rate. So that's why the durvalumab has been used after chemoradiation, the similar principle. So coming to the study, specific study, multi-center global study, randomized double-blind placebo-controlled study. All patients stage 3 locally advanced unresectable NSCLC who are not amenable for surgery under chemoradiations. Definitely, it was only concurrent chemoradiation, at least 2 cycles of platinum-based chemotherapy. 18 years or more, ECOG PS0 or 1, estimated life expectancy more than 3 months, and all the tissue was collected for the biomarker analysis. So patient was randomized to durvalumab versus placebo in 2:1 randomization after completion of concurrent chemoradiation from day 1 to day 42 in case the disease was non-progressive. That means patient has to be has response to chemoradiation with either complete response, partial response, or stable disease. The therapy was for 1 year, durvalumab 10 mg per kg every 2 weeks with a matched placebo. Co-primary endpoint, PFS by BICR or the overall survival. Coming to the baseline characteristic, all were pretty matched. EGFR mutation positive was 6% in both the arm. and most patients as either 3A, 3B. PD-L1 expression less than 25% is 40%, more than 25% in 25%. So raised 40%, the status was not known because the block was not available for biomarker analysis or the tissue was inadequate. Most of the all the patient received concurrent chemoradiation. 1/4 of the patient received induction chemotherapy, though that is not a standard of practice to give induction chemotherapy before giving concurrent chemoradiation, at least not at our center. Coming to the 5-year updated overall survival, the median, if you see, the median OS was 47.5 months in favor of placebo versus 29.1 months, almost 4 years. The stratified hazard ratio for death was 0.72, that is 28% reduction in death. So this is the 5-year data, 33.4% versus 42.9%. And if you see, there are some tailing effect in immunotherapy arm. So clear-cut OS advantage, and this is the only strategy so far that has shown. So any consolidation strategy that has shown overall survival benefit after the concurrent chemoradiation. The first and only approved IO to demonstrate 42.9% of OS in 5 years. So almost half patients are alive at 5 years. Coming to the another co-primary endpoint by Bivas is a PFS. If you see the PFS, 16.91 versus 5.61. Great benefit, almost triple. The hazard ratio was 0.55. That is 45% reduction in progression. At 60 months, at 5 years, the PFS rate was 33% versus 90%, almost double. First and only approved IO to show sustained and durable PFS of 33% at 5 years. Then almost one in each 3 patients are still progression free at 5 years. That is phenomenal. So these are 2, 3, or 4 year, 5 year data. If you see the hazard ratio, almost similar. So 5 year data demonstrate the continued benefit of specific study. It did favor all pre-specified subgroup except EGFR mutation positive, though the subgroup analysis was very small, only 7%. So PFS again, all subgroup favors the use of durvalumab, except again EGFR positive. So coming to the pattern of disease progressions, intrathoracic progression is 36%, extrathoracic only 7%. So disease decreased rate of progression 45.4%. As I said, the hazard ratio for PFS was 0.55, and the majority of the progression was intrathoracic. That gives a very good local control. This is again pattern of disease progression. Time to intrathoracic progression only or death, 25% in 2 months for durvalumab versus 9 months placebo. For subsequent therapy after discontinuation of durvalumab, in durvalumab arm, 40% of patients and 50% of patients in the placebo arm receive subsequent therapy. So that means almost half of them receive subsequent therapy. Systemic therapies are most common for subsequent anti-cancer treatment in both durvalumab and placebo, because definitely most of the patient has either intrathoracic or extrathoracic combined progression that were not amenable for any local therapy. Best objective response rate by first subsequent therapy, I think this is just a subgroup analysis. So definitely conclusion are precluded given the small sample size, a large number of patients with non-available for missing data. Definitely that was not the endpoint of the study. Safety summary, serious AE, coming to the serious AE, 29% versus 23%. Any grade pneumonitis was 4% in durvalumab or 25% placebo. These are definitely only radiation pneumonitis. Coming to the grade 5 pneumonitis, 5 patients in durvalumab versus 5 patients again in placebo. Discontinuation rate almost similar. And AE of special interest, that is because of IRA, definitely 67%. 2/3 of patient has immune-related adverse event in durvalumab. So again, coming to the safety summary based on the time from radiation, this is less than 2 weeks versus more than 2 weeks. That means the starting of durvalumab from the completion of radiation. If you see any grade pneumonitis or radiation pneumonitis in less than 2 weeks time, 39% versus 17%, and if you started after 2 weeks, almost similar, 32% versus higher toxicity in placebo arm. So that means if you start durvalumab as early as within 2 weeks, there is not much of increase in radiation immunities if you start that earlier. And we know that the subgroup analysis shows that if you start the durvalumab as early as possible, the outcome is much better. Coming to the use of durvalumab in real world, this is a specific real world study of durvalumab in real world scenario. It's an international observational study. All patients who received durvalumab in clinical setting has been included. This is almost 1,400 patients from 290 sites in 11 participating country. Coming to the histological subtype, squamous 1/3, 2/3 is non-squamous. Chemoradiation type, concurrent chemoradiation was 76%, sequential was 50%. Both are included. As we know that we do use durvalumab even after sequential chemoradiation as a maintenance strategy. PD-L1 expression more than 1%, 72%, less than 1%, 17.9%. As expected, that 2/3 of patients have PD-L1 expression more than 1%. Majority of the patient was less than 75 years of age. And as I discussed, 15% required sequential chemotherapy before receiving durvalumab. Median PFS 21.7 months. In Pacific trial, it was 17 months. So the median PFS was comparable. The median duration of starting of durvalumab after chemoradiation was 56 days. Please remember that in the study, in the Pacific study, it was allowed up to 42 days, and there are many patients who did receive durvalumab within 4 to 2 weeks. But we know in clinical trial setting, many of the patients have long-term, has prolonged toxicity of chemoradiation, and they sometimes require longer time, and before starting durvalumab. So we do start durvalumab in few of the cases even after 2 months and 3 months. So the median duration of starting durvalumab in this study was 56 days. That means almost 8 weeks. Coming to the safety outcomes, AEs was 17% discontinuation rate, and the median time from durvalumab start to discontinuation was 2.8 months. No new adverse events was seen. All adverse events are comparable to Pacific trial. Patient with pneumonitis, moderate event was 8.4% only. So median time to onset of pneumonitis or ILD from the durvalumab was 2.5 months, and definitely 2/3 patient received corticosteroid. The first and only approved immunotherapy to improve the OS and PFS in Stage III patient is durvalumab, and definitely an improvement of 11.2 months of PFS from the absolute benefit. So 5-year PFS rate is 33%. 1 in each 3 patients remain progression free. And again, this similar benefit has real world evidence. 32% reduction in death. Median OS was 4 years. Safety tolerability. 15.4% treatment discontinuation durvalumab and 60.3% due to pneumonitis. Most commonly know other than the typical eye is a cough or respiratory infection, rash, sometimes transaminitis, colitis, all this. So I think I'll stop here. So both this study did show that it is effective. It can increase outcome as far as high as 40, is crossing 40% as compared to 15% chemoradiation. So definitely it is one of the landmark phenomenal improvement in terms of outcome with a manageable safety profile. So thank you for your patience. Denny, you are muted.
I'm unmuted. So sorry. Thank you, Dr. Bivas. So this is truly a remarkable drug, durvalumab, in this scenario which was unexplored. So Dr. Bivas, just one question to you.
Yeah.
How common in your practice are you seeing any case of tuberculosis living this scenario? So any IO drug, any indication. So how common is the tuberculosis in your practice? And are you screening for those for latent tuberculosis upfront?
So most of the cases, if the patient has past history or any symptom, we do bronchial lavage and low TB. I can recall in the last 1 year, I have almost 10 patients diagnosed with TB with concurrent with CLM. And last 3 months, we have 3 patients who has concurrent TB and we could not give durvalumab. So it's not uncommon.
Any IO drug, barring this durvalumab.
We are not using any IO drug if the patient has active TB or at TB at least within the last 2 years.
2 years. If patient develops tuberculosis on IO drug, So
We
will you
have
stop
stopped.
IO drug forever?
It did happen, and we have stopped.
So okay. Is there any guideline to stop it,
No, there is no
or if
guideline.
TB is
Patient
controlled, if TB is controlled and disease is also controlled, well controlled, any indication, any IO drug.
in
So
stage three
can't
setting,
we?
maybe in stage three setting, curative setting, maybe I'll be hesitant to give and get the TB uncontrolled and patient die. But in a stage 4 settings, sometimes we are compelled to do. So I give at least a few months a gap, get the ATT and the TB control, and then resume if there is no other treatment strategy exists. So sometimes I bridge over with chemotherapy.
Thank you, Dr. Bivas. So after this talk, so I would